Okay. So it's my pleasure to introduce our speaker, Rhonda McNichol-Whiteman. Rhonda is the stroke best practices clinical nurse specialist at Hamilton Health Sciences. She supports teams within Hamilton Health Sciences and the Central South Ontario Stroke Network to implement best practices for stroke care across the continuum. Rhonda completed her Master's of Nursing from the University of Toronto in 2008 and her Bachelor of Science in Nursing from McMaster University in 1989. She has maintained her Canadian Nurses Certification in Neuroscience Nursing since 1994. She holds a part-time assistant clinical professor in the School of Nursing, Faculty of Health Sciences, McMaster University in Hamilton, Ontario. She was the co-investigator on a pilot study of the evaluation of the Family Informal Caregiver Stroke Self-Management Project, impact on caregiver, psychosocial, emotional, and health needs. It was a research project in collaboration between the March of Dimes Canada, Hamilton Health Sciences, McMaster University, and VON Hamilton. She was a member of the RNAO Stroke Assessment Across the Continuum Best Practice Guideline Development and Review Panel. She has presented a number of papers at regional, provincial, and national conferences over her 35-year nursing career in neurosciences. And with that, I'll turn it over to Rhonda.
Thanks so much, Tina. It's my pleasure this afternoon to provide this presentation on the Canadian Neurological Scale. What I'm hoping to cover this afternoon is really to provide a bit of background and the evidence related to the Canadian Neurological Scale, to identify the steps to complete the Canadian Neurological Scale, and to walk through some of the scoring using some case scenarios. So when we look at the Canadian Neurological Scale, we know that up to 50% of stroke patients that are admitted to hospital may go on to deteriorate clinically after admission. Early detection of the neurological deterioration and early interventions in these patients can limit the neurological damage and improve their outcomes. Despite all our technical advances, the sensitivity of having skilled observers using standardized tools to detect these changes in stroke patients cannot be surpassed. The Canadian Neurological Scale was developed in 1985 by Dr. Robert Cote and Dr. Vladimir Hashinsky as a complementary tool to the Glasgow Coma Scale. It was developed for the assessment of stroke patients who are alert or drowsy. It also is a standardized tool that addresses the issue of aphasia. It is developed to evaluate the impairments related to the stroke. And so in contrast to the Glasgow Coma Scale, it measures the worst deficit or the worst impairment, not the best response that the Glasgow Coma Scale does. It is a simple and easy to use tool that takes about 5 minutes to complete, so really allows it to be done repeatedly at the bedside, especially in that hyperacute phase in the emergency department and on the acute stroke unit. It is one of the tools, assessment tools identified in the Canadian Stroke Best Practices to be used to rapidly assess stroke patients in the emergency department and early acute phases of care. As it is a standardized assessment tool that addresses the deficits we see in our stroke patients, though it was initially developed for assessment in the hyperacute and acute phase, it is a tool that can be utilized to better assess the neurological status of our stroke patients in a rehabilitation and across the continuum. The Canadian Neurological Scale has good and strong psychometric properties. It has excellent internal consistency for all of its domain with a Kronberg's alpha of 0.792. The inter-rater reliability calculated by the Kappa stats was adequate to excellent in all of the domains. A number of studies looked at comparing the Canadian Neurological Scale findings to the NIH and standard neurological exams and found it to be adequate and excellent correlations in all domains. The initial CNS score was also found to have predictive value, in that the initial CNS score can predict death within 3 to 6 months and morbidity and recovery of ADLs within 3 to 6 months. For example, those whose initial CNS score was 11 or more, 2.1% had died within 6 months, versus patients whose initial Canadian Neurological Scale was less than 9, 13.2% had died within 6 months. So let's do an overview of the Canadian Neurological Scale. The Canadian Neurological Scale has 2 components. Section A is mentation, which is made up of level of consciousness, orientation, and speech screening. Part 2 is motor function testing. And you can see motor function testing has 2 components. It has Section A, which is for patients who have motor function where they have no comprehension deficit. And so they're able to understand and follow commands, can resist the resistance of the examiner. And A2, motor function in patients who have a comprehension or receptive deficit. So they're not able to resist the examiner and follow commands. You see, we look at testing in the face, arms, and legs. The difference between A1 and A2 is A1, we do proximal and distal arms, and A2 are in proximal and distal legs, where A2, we just do face, arm, and leg. So let's move on to Section A mentation. Section A, level of consciousness, is based on our observation of the patient. The scoring here is either alert or drowsy. Alert is defined as, is the patient awake, alert, spontaneous eye opening? Do they have normal level of consciousness? Compared to that, drowsy is defined as a patient who needs to be stimulated verbally or with light touch. They may awake and alert for short periods, but they tend to doze. So again, for level of consciousness with the CNS, it's either alert or drowsy. I did say that the Canadian Neurological Scale was a complementary tool to the Glasgow Coma Scale. So if your patient is more stuporous, responds, needs loud verbal stimuli or strong touch to rouse them, does not wake up completely awake, really responds only to deep pain with either purposeful, non-purposeful movement or no response, you would use the tool that best evaluate coma, and you would use the Glasgow Coma Scale with that patient. So depending on your patient's status in the early phases of their stroke, you may find you're using different tools depending on their clinical status. Next, we move on to orientation. Here we assess 2 domains, place and time. So we ask the patient, where are you, what city and place, and what is the month and year? I always wonder, and I mean to ask Dr. Cote or Dr. Helshinsky when I'm at conferences, why they didn't look at assessment of who the person, assessment to who are you to person. I think because they knew they were adding a more detailed speech assessment that would take more time, they really wanted a very quick mechanism to capture, and something that was also in a bit more alignment with the NIH. So here, the patient doesn't need to say if they're in Hamilton, I'm at the Hamilton General Hospital. If I say I'm in Hamilton in a hospital, that's fine. They only need to say the month and the year. And so again, you may say, well, why don't they need to know the date? I'm sure if I did an informal poll, what was the date? Many of us likely would not know what the date is. For the record, it is August the 22nd. Hopefully I got it right. Here, Speech can be dysarthric for the patient, but it must be understandable. Scoring here is oriented. The patient is oriented to both place and time, or disoriented, not applicable. The patient doesn't answer the questions about orientation correctly, cannot express themselves at all, does not answer the question. That would be disoriented or not applicable. There are no half marks, so you can't say oriented to place, oriented times 1. It's either oriented or disoriented. Writing the response to these questions is okay because we are looking at their orientation. If the patient English is not their first language, and you're utilizing a translator for orientation and the speech testing, especially because the patient may move across the continuum from ED to ICU or to the stroke unit, it's important that you flag that if you're using the hard copy form that, was done with a translator, or many of the electronic forms have comments. Because what we don't want to know is, we know that a change of more than 1 point could be a trigger that there's been a change in the patient's neurological condition. We just need to know that if a score is, say, for example, 8, it's with a translator or not, so that we can determine if that change is a clinical change or the fact that they don't have a translator. The next section of the Canadian Neurological Scale is the most difficult to work through. And when we look at here, the scoring for speech screening is either the patient has a receptive deficit, they have an expressive deficit, or they have normal speech. So there are 2 levels of testing that you're doing. First, we're starting for a receptive deficit, then we're moving to assess for an expressive deficit, and I'll walk through each of those. The first that we look at is assessing for a receptive deficit. Here, you're asking the patient to close their eyes. You can repeat the question, but do not mimic what you want the patient to do. Don't go, "Can you close your eyes?" You just want to ask them to do it. You want them to point to the ceiling, and does a stone sink in water? So you have 2 one-step commands, and then one that's a bit more complicated. The patient must do all 3 to move on to expressive language testing. If the patient cannot do all 3, you stop. The patient is scored as having a receptive deficit, and we go directly to A2 motor testing. If, though, the patient can close their eyes, point to the ceiling, and indicate, yes, a stone sinks in water, we move on to expressive deficit, assessing for an expressive deficit. I did say earlier that the Canadian Neurological Scale was developed in the mid-80s with common objects that were found in the clinical setting. And many of you, I'm sure, were not nursing during that time. I was, fortunately. And again, we often had a pen, we had a watch, we may have our keys for our narcotic cupboard. So these were common objects that were in the clinical setting. What many units have done is creating pictures of these 3 items to help with the testing for patients and put them on their blood pressure cuffs. So what we look at here is we look and we show them, it's a naming and identifying the use of each object. So we want to say, what is this? A pen or a pencil? What is this? Show them a watch. And what is this? Show them a key or a picture of a key. Give them time to name each object, and then ask them, what does this do? What does this do? What does this do? What we don't want to do is say, what is this and what does it do? The reason we don't want to do that is that's a two-step command. We know many patients may have difficulty with multiple sequencing, may not be able to do multi-step commands. And so they're still the patient is trying to understand what is it, and they've forgotten or haven't processed what does it do. So you can say, what is this? Give them time to respond. What does this do? But break it down into one-step commands. If the patient can name all three and identify their use, they are scored normal speech. If, though, the patient can't state the name of each and the use, they are scored as an expressive deficit. The patient's speech can be slurred, but as long as you can understand the words that are being said, they don't lose points, and they could be scored normal speech with just indicating SL beside the scoring. If, though, their speech is so garbled and so dysarthric and incomprehensible that you can't understand what they're saying, they may be scored as an expressive deficit. I hope that makes sense. It's really important when you're doing the orientation, the receptive deficit, and the expressive deficit that you are consistently doing the tool using the questions and the objects that are identified in the tool, because that is what the validity, the consistency, all of the psychometric properties of the tool was done. We don't know if we choose a different thing every time, if it's reliable and we'll get the same response. Because we're looking at expressive speech in this situation, if the patient writes the response, that is not acceptable. We're looking at their expressive speech in this case. So let's go to a case scenario to work through how we would score mentation. So we have John Smith, who's a 72-year-old man who was brought to hospital when he developed stroke symptoms at home. In the emergency department, his neurological status was alert, oriented to place and time. He was able to follow one-step commands. He was able to follow a more complicated question, able to name simple objects and identify their use. He has left facial weakness and dense, flaccid left-sided hemiplegia in his left arm and leg. So let's move on and score mentation. So here we look at level of consciousness. The case scenario said that John was alert. So John would be scored alert. He would get a score of 3. If we move on to orientation, it says he's oriented to place and time. So in this situation, John would be scored as oriented. He would receive a score of 1. When we move on to assessing for receptive deficit, he's able to follow one-step commands, and he's able to answer a more complicated question. So based on that, in our case scenario, he does not have a receptive deficit. So we move on to expressive. Here, he's able to name simple objects and identify their use. So again, John would be scored as normal speech. So when we look at scoring, you can see here on a sample form, he would get 3 for level of consciousness, 1 for orientation, 1 for normal speech. His total mentation score is a 5 in A. So let's move on to assessing motor function, section 2. As I said before, there are 2 ways we can look at this, either A1, which is motor function with no comprehension deficit, or A2, motor function with a comprehension deficit. In this situation, John, because he's able to get normal speech, he will move on and assess A1, motor function testing, no comprehension deficit. So the first we look at is face. Here we're looking to ask the patient to smile, to show them their teeth, their gums. You're really looking for, as we can see, is there any flattening of the nasal labial folds? In this case with Stephanie, we're not seeing any, which I'm sure she'd be most pleased with, considering she's my office mate. And we would score the side of the deficit. So scoring here is either none, no weakness, the grin is symmetrical, there's no asymmetry of the face, or weakness present, there's facial asymmetry, one corner of the mouth is lower than the other, either at rest or showing their teeth. Then we move on to proximal arms. There's two ways that we can test proximal arms. You can either do it, as Stephanie's shown, sitting, using abduction of their arms to 90, or if the patient's lying in bed, having them raise their arms to 45 to 90 degrees. In the proximal and distal arms and legs, you're always putting resistance on the large muscle groups, never on the joints. When we look at scoring, and it's the same scoring for the proximal and distal arms, proximal and distal legs. So I'll go in depth with the proximal arms and then we can review. I always recommend when I'm teaching is to have the patient do the movement that you want. So for example, as Stephanie said, get them to abduct their arms, get them to raise their arms up in front of them. Because what differentiates mild versus significant is mild, the patient can do full range of motion against gravity, but cannot oppose resistance of the examiner. Versus significant is they can't completely overcome gravity in full range of motion. The movement is less than 90 degrees. So by knowing that I can do this or this, you automatically know that both my proximal arms are at least a mild. The other thing I find is sometimes it's challenging if you're asking the patient to push up against me while you're putting resistance down. Sometimes it's hard to tell, is it none, no resistance, or if it's mild, where again, if the patient's up, then you can see, okay, yes, there's a bit of drifting in perhaps that one arm, or no, they're able to hold them up completely. Total is total weakness. This is defined as absence of movement in the muscles or only contraction of the muscles without movement. So when we look at this scoring in A2 for proximal and distal arms, it's none, no resistance. So full range and able to examine or resist the opposing force of the examiner. Mild, they can do full range, but can oppose resistance of the examiner. Significant, cannot overcome gravity in range of motion. The movement is less than 90 degrees. And total weakness, absence of movement in the muscles or only contraction of muscles in each movement. And that's the same for distal arms, proximal and distal legs. So now if we go on to distal arms, patient can be tested with either sitting or lying in bed. You're asking the patients to make a fist and extend their wrists, as you see here. You're comparing range of motion in both wrists simultaneously, or if the patient has weakness in one arm, you can support their proximal arm, test one limb at a time. You're always testing both, but scoring the side of the deficit. As I said, the scoring here is the same. None, no weakness, mild, significant, and total, using R or L to score the deficit. When we move on to proximal legs, again, this is ideally that you have the patient in bed. You're always testing both limbs. Here you're having the patient flex their hip to 90 degrees. and pushing down on each thigh one at a time. So in this situation, in the picture depicted here, we know that Stephanie's right leg, proximal leg, is at least a mild. And then if we apply resistance and she can overcome, it would be none versus mild. If Stephanie had some leg movement but couldn't flex their hip to 90, that would be significant. If there was no movement, it would be total. Finally, on A1, we do distal legs. Here we're having the patient dorsiflex their ankles, bringing their toes to their nose. And if they bring their toes and touch their nose, they get bonus points. No, they don't, just trying to inject some humor. But get their toes and feet, dorsiflex their feet. Again, you're pushing down on each toe, foot one at a time. Scoring is the same, none, 1.5, mild, 1, significant 0.5, and total weakness 0. So if we go, if we go back to our case, John has left-sided facial weakness. He has dense left-sided hemiplegia in his left arm and leg, and I've defined it as that the left arm and leg are flaccid. So when we look at John's face, it's saying he has left facial weakness, so we would score him as being facial weakness present with an L, and he would get a score of 0. If we look at proximal arms, again, we would look at total because there's no movement. So it would be total on the left in proximal arms. Distal arms, again, would be total, 0 on the L. Proximal legs would be 0, total, and distal legs would be total. And so you can see here, face would be a 0 on the left. Proximal arms would be a 0 on the left. Distal a 0, proximal and distal leg 0. So a total CNS score of 5. So now we'll review section 2, A2, motor function with a comprehension or receptive deficit present. So as we said before, if the patient, when you do speech testing, they can't close their eyes, they can't point to the ceiling, and a stone can't identify that a stone sinks in water, we stop language testing and proceed to A2 motor testing with a comprehension deficit. Here, because we know the patient isn't understanding simple commands, they're not going to be able to understand and follow commands, so won't be able to apply resistance as we're moving forward. So here we look at face, total arm, total leg. So here, what we're looking at is having the patient mimic your grin. Most patients, if you smile at them, they will attempt to smile back. Certainly became challenging with our assessments, with our patients wearing masks, the staff wearing a mask. So just certainly quickly pull down, have them assess, put the mask on, doing the same with the patient. Here, you're looking for asymmetry of their mouth and nasal labial folds. Scoring for A2 face is either it's symmetrical, so no facial weakness, or it's asymmetrical. There is weakness on the side. If you're not able to get the patient to follow your commands, to mimic your grin, you're just not able to determine, is there any flattening of the nasal labial folds? You can do central stimuli to see if the patient grimaces and see if you have a difference in weakness of the face. But usually I find you can pick up and determine that without having to resort to painful stimuli, but you can do that. Again, always looking at the central pressure to determine that. Then when we look at motor function in the arms in A2, here what we're doing, as you can see with Stephanie, is you're raising the patient's arms out in front of them at 90 degrees and seeing if they can maintain their arms raised equally for 3 to 5 seconds. Scoring is either equal movement of both arms, or unequal. So one arm, they can't maintain their arms equally. One, they're able to maintain. The other, they can't hold up at all, or there's mild drifting. Again, as I said, you can, if you just can't determine if there's a weakness, you can do central pressure to compare responses. This is an area where, and I know that the neurologist really wanted to be very objective in that it's either equal or unequal. But if I developed the tool, which I did not, there is a way, there's certainly a difference between mild drifting after 3 seconds versus the patient can't hold their arm up at all, or the right arm is flaccid. However, for A2, it's either equal or unequal. Those additional assessment points, you would just document either in your system review, or if there's a comment section on the form for that. When we look at A2 motor function of the legs, again, you're flexing each leg up one at a time, seeing if the patient can keep their leg up equally raised for about 3 to 5 seconds. You hold up the right leg, you raise up the right leg, see if they can hold it up for 3 to 5 seconds. Lower the right leg, raise the left leg, and see if it's equal or unequal. So let's do a case study to walk through what our scoring might look like with a patient in this situation. So we have James Brown, a 65-year-old man who presented to the ED with sudden onset of stroke. He is alert. He's not oriented to place or time. He's not able to answer simple one-step commands. He's not able to answer the question if a stone sinks in water. He has right-sided facial weakness. He can keep his left arm and leg raised for 5 seconds, but his right arm and right leg drift to the bed within 2 seconds. So let's walk through each of the scoring. So if we look at level of consciousness, James was alert, so he would be scored 3. It tells me that he is not oriented to place or time. So James would get disoriented. When we look at assessing for receptive speech, James was not able to follow simple one-step commands. He wasn't able to identify a stone sinks in water. So we would then score him receptive deficit testing. We would move to section A2 motor function. When we look, it said James had facial weakness on the right. So he'd be scored asymmetry of the right. When we look at his arms, he's able to hold up his left arm for 5 seconds, but his right arm drifted after about 2 to 3 seconds. So James would be scored unequal on the right. If we then also go to motor function of the legs, the same thing. He's able to keep his left leg up for about 5 seconds, but his right leg drifted after 2 to 3 seconds. So it would be unequal on the right. So here, if we look at scoring, what you can see is here, James was alert. He was disoriented. He had a receptive deficit. So his total mentation score was a 3. Because he had a weakness on the right, he got 0 for face asymmetry, unequal arms on the right, unequal legs with weakness on the right. So James's total CNS score was a 3. So what you can see is when Dr. Cote and Dr. Wyszynski developed the tool, they built in some weighting for one, motor function and the impairment of that, but also the impact of receptive deficits and expressive deficits. And so you can see, though James's weakness, maybe mild weakness on the right side, it's still a weakness, but that comprehension receptive deficit has a significant impact on his recovery and his overall functional improvement. So how do we score the CNS? A minimum score is 1.5, which is very low. It is a very severe stroke. And 11.5 is a normal CNS score, which means the patient has no stroke deficits. We know a higher CNS score indicates the patient has less severe deficits. So here, a CNS greater than 11, the patient will have more favorable outcome. Lower CNS scores indicate the patient has more stroke impairments. So a CNS score of less than 9 is associated with increased morbidity and mortality after the stroke. What they found when they were looking at the tool is they found a decrease of more than 1 point from the previous CNS score is an indicator that there's been a change in the patient's status. And it requires notification of the physician because it may mean that the patient's having a change in their neurological status. They may be having a complication if they've received hyperacute treatment, or it may be that the patient is developing a medical condition that is impairing their neurological status. What I always say is, though that decrease of more than 1 point from the previous CNS is that trigger for your good nursing judgment, when you're calling the physicians, describe what the clinical change is. As you'll see when we saw these 2 case scenarios, and we'll do with a couple of more case scenarios, the score can mean a lot of things, but describing that the patient has gone from being alert with an expressive deficit, mild weakness on their right side to now being drowsy, receptive deficit, disoriented, and significant impairment very clearly presents what that change in clinical condition is to the physician and helps to warrant, what are the next steps to identify what's contributing to the patient's condition. So how often should I use the CNS score? Again, it was initially developed to be used in sort of the emergency department and acute care. But as I said, it is a tool that could be used, especially we know patients are going to rehab much earlier and quite acute as part of their neurological assessment and rehabilitation. What I've included is some examples of when you would do it in a patient post-thrombolysis, acute patient who's not receiving thrombolysis, but certainly follow your organization's policy because sometimes post-monitoring protocols are different based on your organization. So certainly when a patient receives thrombolysis, so either alteplase or tenecteplase, we know most of the complications occur right after either the bolus or the start of the infusion, the first 24 hours, and then gradually diminish. So obviously, we're monitoring them very closely, Q15 minutes for the first hour after the bolus or the start of the infusion, Q30 minutes times 2, Q1 hours for 16 hours. Our protocol is Q2 for 24 if stable, Q4, and then often it goes to Q shift. Certainly depending on the patient's clinical condition, they may go to Q shift sooner than that. In an acute stroke patient not receiving thrombolysis, typically for the first 48 hours, we'd monitor their Canadian Neurological Scale for the first Q4 hours for the first 48 hours. We know those first 48 to 72 hours are the most critical in when we may see changes in our patients. Based on that, if the patient's condition is stable, you may decrease it to Q-shift as part of your head-to-toe neurological assessment of the patient. Certainly, if you are utilizing it within the emergency department or an acute stroke unit with a high-risk TIA patient, I would utilize it when your vital sign and neurological monitoring are ordered, because you really want to use the tool that's picking up on those subtle changes. Certainly in rehabilitation, cross-continuum, again, it will give you a good baseline assessment of those patients' neurological functions, much more so than a Glasgow Coma Scale. As we know, the Glasgow Coma Scale was developed to evaluate coma. The majority of our stroke patients, certainly a high proportion of our stroke patients, are not having altered level of consciousness. They may be drowsy, they may have speech difficulties, and they have motor impairment. So it's a much better tool to assess the deficits we're seeing in our stroke patients. So let's do 2 more case scenarios before we finish up with any questions. So here we have a 50-year-old woman who presents to the emergency department with sudden onset of stroke symptoms. She is alert. She's oriented to place only. She's able to follow simple one-step commands. She's able to nod to a question if a stone sinks in water, but not able to identify a key, a watch, or a pencil, or indicate the use. She has right-sided facial weakness. She's able to lift her right proximal and distal arm off the bed, but not able to do full range. She has no weakness of her left arm. There's no spontaneous movement in the right proximal and distal leg, and no weakness in the left leg. So how do we score this patient? So here, the patient is alert, so would receive 3 for alert. The patient is only oriented to place. So again, as I said at the beginning, they don't get oriented ×1. They're scored as disoriented. The patient was able to follow simple one-step commands, so could close their eyes, could point to the ceiling, and could nod that a stone sinks in water. So didn't have a receptive deficit, but could not identify the key and the watch and the pen and what they do. So in this situation, the patient was scored as a receptive deficit, receiving 0.5, so received 3.5 for mentation. She had right-sided facial weakness, so received present for face and indicating it was on the right. She was able to lift her right proximal and distal arm off the bed, but couldn't do full range. So again, here was scored significant for proximal, significant for distal arm with an R, indicating it was on the right side. Her left arm had no weakness, but remember, we're only scoring the worst deficit. So here we score just the worst deficit when we're scoring the CNS. Her right proximal and distal leg had no spontaneous movement, so received total weakness for proximal and distal leg. So the total CNS score for this case was 4.5. So our last case is a 40-year-old woman who presented to the emergency department with sudden onset of stroke symptoms. She rouses to verbal stimuli. She's not oriented to place or time. She's able to follow simple one-step commands and answer a stone sinks in water, but couldn't identify a key or watch or a pencil or their use. Had right-sided facial weakness, was able to lift her right proximal and distal arm off the bed and do full range, but was unable to overcome the resistance of the examiner. There was no weakness in the left arm, was able to lift her right proximal and distal leg off the bed, but not to full range. There was no weakness in the left leg. So here, what you would see is the patient is drowsy, needed a verbal stimuli to wake the patient up, was disoriented because she wasn't oriented to place or time, was able to follow one-step commands and answer a stone sinks in water, but wasn't able to identify the key, the watch, the pencil, or their use. So was scored an expressive deficit. So because she had an expressive deficit, we go to A1, motor testing. She had right-sided facial weakness, so it was present on the right. She was able to lift her right proximal and distal arm off the bed, do full range, but couldn't overcome the resistance of the examiner. So, and that would be scored mild, interproximal and distal arm on the right. Again, we score the impairment, so the left weakness is not scored, that it was normal. Was able to lift her right proximal and distal leg off the bed, but not to do full range. So in this situation, her legs were significant in proximal and distal, and so the total CNS score was a 5. So as you can see here, was scored a 5. Our first case was John, who was also scored a 5. And so that's why it's really important to indicate if there's a change in condition, what is that clinical change to the physician? Because though that change of more than 1 point is the trigger, describe what that clinical change is. I'll pause now quickly for questions. I do have built in, as we go along, some opportunities for resources and tools that we can share with individuals. You also have the QR code to complete the evaluation form. So if you don't have questions, if you can take a minute to complete the evaluation form either through the QR code or the link in the chat. Tina, I see there's a couple comments in the chat and a question, but I'm not sure what they are.
Yeah, so the comments in the chat are the links to our archived Stroke 101 webinars and also the evaluation link. So we did have a question asking if the presentation slides would be available, and I responded to that. So everyone is aware, yes, they will come. You'll get a link to it in the follow-up email tomorrow.
Are there any questions?
Yeah, so feel free to use the Q&A. You can also raise your hand if you'd like to ask the question verbally, or use the chat if that's easier for you. So we'll give people just a few minutes. And certainly, if questions come to you after the presentation, after we're completed the webinar, you will have my email in the follow-up message that you get from Zoom, and please feel free to reach out to me. Okay, so we have a thank you from Kavita. Thank you for the presentation.
Thank you. Okay, well, why don't I'll just go on and sort of look at some resources that may be helpful to support in tools and your nurses on the units to move forward. So again, some of the things that we've utilized that have been helpful as we're supporting nurses as they're completing the Canadian Neurological Scale is developing this sort of one-page hard copy reference sheet that again can be laminated either on your blood pressure machines, at the bedside. Also, there are some laminated pocket lanyard cards that again staff can pull out as they go. Unfortunately, the stroke assessment pocket guide and the CNS card that was in that is no longer being produced by Heart and Stroke Foundation, but there is a provincial subgroup with the Ontario regional educators and some of the best practice coordinators to look at how can we create some of those key resources that were so helpful for our teams in that pocket card to be available. Also, as I said, some of the things that units have found helpful is getting pictures, laminating pictures of the key, the watch, and the pen, and putting them on the blood pressure cuffs or on a ring for the nursing team to have so they can do it correctly and use the tool. Certainly, there are many sample sort of policies that I'm happy to share with sites should they require sample of sort of hard copy documentation tools, or certainly we recently moved to Epic at Hamilton Health Sciences. So I do have certainly tools of how we set that up electronically that maybe individuals be interested in. I'm happy to share. And here are my references, and I don't know if there's any final questions, Tina. I'll stop sharing.
We have a couple more thank yous. Angela Crane says, thank you very much. And Sylvia Young said it was excellent.
Well, thank you. Thank you very much.
Okay. Okay. Well, certainly there's always the opportunity to reach out to me. Oh, I see one more. Okay, so Angela Crane has commented here, the pocket card also misses that third question of, does a stone sink in water? We've had a lot of success at GNGH, which is the Greater Niagara General Hospital, with laminating photos of the three objects and having a pen light, flashlight available for pupil assessments also.
Yeah, no, that's a great point, Angela, and thank you. Again, certainly when we look at our neurological assessment, which I should have said is, again, we are doing sort of the vital signs, again, looking temperature, blood pressure, pulse, respiration, O2 sats, the CNS for neurological assessment, and pupil assessment. So again, though not part of the Canadian Neurological Scale, certainly it is part of your neurological assessment that you would see. So thank you for flagging that in my aging memory, Angela, to make sure we capture it. So yeah, really important that having all the tools that the team needs so that they can do it correctly.
Okay. Okay, well, thank you very much, Rhonda, and thank you for to the audience for your kind comments as well. As you remove yourself, or as you exit the webinar, you will have the option of clicking on the short evaluation if you've not had a chance to do it with either the QR code or the link. We really do appreciate hearing and learning from our audience as we prepare education events. So again, tomorrow you will receive a recording of the webinar with a link to the presentation slides as well. And any questions, please feel free to follow up. We will have ongoing Stroke 101 webinars, and we anticipate our next one to be mid to late September. And so wish you all a great rest of the afternoon.
Thank you.